Vandana Khungar, a transplant hepatologist and the director of inpatient hepatology at Penn. I'm very pleased to present to you today our work to reduce readmissions in the cirrhosis and the post-liver transplant populations through our program, LiveBetter. I would like to introduce you to one of our patients, Dave. He's a 63-year-old gentleman with cirrhosis due to fatty liver. He did quite well for 5 years since his diagnosis, but more recently developed fluid overload in the form of lower extremity swelling and abdominal swelling. He was admitted to our hospital and treated with water pills and did quite well. He was discharged home. Unfortunately, patients like Dave and others who have cirrhosis have approximately a 1/3 chance of being readmitted to the hospital within 30 days after discharge. He became progressively confused at home. His family did not know that this was a symptom of liver disease, and he was readmitted, this time to the ICU. We know that being readmitted has a significant impact on our quality of life, and we know that it is costly and inconvenient for patients and families. Morbidity and mortality are increased in the hospital, and we know that it reduces your chance of making it to a liver transplant. Our team wondered, what could we have done differently to prevent Dave and his family from going through the pain and suffering of an ICU admission? With Dave in mind, we moved forward in thinking about our patients and how we could improve their care. We know that nationally, approximately 600,000 U.S. adults have cirrhosis. Of the 7,000 waiting for a liver transplant annually, less than half will receive one. At Penn, we have 850 cirrhosis admissions per year. In that population, 29% of them are readmitted within 30 days of discharge. In the post-liver transplant side, we perform approximately 120 to 150 liver transplants yearly with excellent outcomes. On that side, we have a 32% 30-day readmission rate, for a total aggregate cost in readmissions alone to Penn of $21.6 million yearly. The complications of cirrhosis most likely to result in a patient needing to return to the hospital are fluid retention and confusion, as well as infections. In the post-liver transplant state, those are medication errors due to a new long list of medications they have to manage, as well as infections and possibly surgical complications. These patients are extraordinarily difficult to keep out of the hospital due to their degree of illness. Many patients with cirrhosis are so ill that their estimated 3-month mortality is greater than 50%. Telehealth has not yet been attempted in this population, but looking to heart failure as a model, we can look at another disease state that has successfully employed the technology. At Penn, looking just at our cirrhosis survey, we know that 29% of patients are readmitted within 30 days. That's a cost of $16.3 million annually. Within these readmissions, 23% are considered potentially preventable. In the transplant arena, 32% of our patients in the last fiscal year were readmitted within 30 days at a cost of $5.3 million annually. Given the scope of the problem, both at Penn and nationally, we developed a hypothesis that we could reduce 30-day readmissions for both cirrhosis and post-liver transplant patients by remotely monitoring their weight, their mental function, their medication adherence, and their temperature. We first began with a remote monitoring approach in which we used 90-day telehealth monitoring by very highly skilled RNs. This was high touch and high cost. RNs were making many phone calls to the patients and sometimes even going out to the patient's home to do a visit. Bluetooth scales, blood pressure monitors, and pulse oximeters were given to the patients with a 4G tablet. Patients with cirrhosis and those who had a liver transplant were eligible, but due to home nursing criteria, very few actually were enrolled. We had very exciting results from this pilot, and we saw that we were able to decrease our readmission rate from 29% to 13% in the intervention population. But despite this initial success, we realized that there was still room for improvement. The problems that we encountered were that our technology was expensive at a cost of greater than $1,000 per patient for a 90-day period. And it was complicated, not just for patients, but also for providers. We realized that our staffing model was simply not scalable, and we knew we were only affecting a narrow patient population. Going forward, our next hypotheses were that we could decrease the cost of our intervention to $50 per patient, that we could automate this intervention and only escalate severe clinical concerns, and we wanted to maintain or even improve the user experience and outcomes. To test our hypotheses, we performed 9 pilots over the course of 3 months. These included experiments to test different methods of enrollment, types of technology, and a variety of staffing models. We know most of our patients' time is spent outside of our direct care. We learned how to enroll our patients in a telehealth program for 1 month after discharge so that we could keep track of them when they're not in the area of direct clinical care. In our first intervention, we used complex, high-cost technology to monitor our patients. But in order to make this scalable and easy enough to use, we had to employ the use of an internal platform called Way to Health. We designed and tested an automated SMS-based solution to engage our patients post-discharge and monitor their weight, temperature, and their medication adherence. This platform let us build in algorithms to flag patients with maximum risk, thereby improving all of our staff's efficiency. We saw that our early pilots were able to inform the design of our final solution, and we learned that patients actually preferred to use their own cell phone and basic digital scales and thermometers over very complex, expensive technology. We also learned that 24% of the time, patients actually wanted the messages to go to a caregiver and not themselves. This highlighted the importance of caregiver support in our particular population. And finally, we found that patients felt engaged, they felt cared for, and even when they were interacting with an automated texting platform. One of our patients, Mrs. L, was enrolled in our automated pilot, and we received an alert that she was gaining 2 pounds every single day. This sparked an escalation to an MD who prescribed water pills for her, and we averted a readmission. Had she not been enrolled in our pilot, she would have been readmitted, as she was previously not in the habit of actually weighing herself. Through this pilot, we were able to meet our patients where they're at by using their own cell phones to text, by giving them emotional and clinical support daily, by getting them in the habit of monitoring their own care and making them active and not passive drivers in that care, and by providing simplicity. Even those patients who were confused from their liver disease could actively engage. We realized also from the provider standpoint that we were very pleased only 90% of messages were handled by the Way to Health platform alone and did not require escalation. We saw that if something needed escalation, it could go to a non-clinician patient liaison. If she felt that something needed further escalation, it would progress to an RN, and finally to an MD or a PA. Only 4% of our total messages required MD or PA support. Our model allowed the right issues to reach the right providers at the right time, and everyone to provide top-of-license care. By lowering our equipment and our staff costs, we were able to decrease our total cost per patient from over $1,000 to $50. We learned that our simple technology worked just as well as complex, expensive technology. We knew that weight, temperature, and medication adherence are effective measurements of readmission risk, and mental function needed to be added. And patients actually needed very few calls from our staff, but when they were needed, these calls prevented readmission. We also realized that we could engage our providers in a scalable model. Our intervention reduced workload for MDs and PAs while helping them keep track of their patients. RNs were able to enroll patients on our inpatient unit within their normal workflow with no disruption. Most importantly, we were able to improve our user experience and outcomes. One of our patients said to us, "This was beautiful and great, and I wish I could stay on the program. It feels like people were watching. It was nice. It wasn't long enough, and I want more." During our intervention, 7 patients had a reason to be readmitted. We were able to capture and avoid 3 of those, resulting in a 43% reduction in 30-day readmissions, or a 75% reduction in potentially preventable readmissions. We know that there is always room for progress in the future as we learn to capture that last 25%. If we were able to reduce readmissions by 43% as we did in our pilot, we could expect to reduce our costs by $6.8 million in direct and indirect costs for cirrhosis 30-day readmissions and $2.2 million for post-liver transplant. While this does not take into account potential reimbursements, we know that we're becoming increasingly more financially responsible for all of our 30-day readmissions. We also know that as we bring this intervention to scale, we will improve the lives of patients at Penn Medicine and nationally in many ways, perhaps most importantly by increasing their survival and the likelihood of making it to a liver transplant, while feeling connected and cared for. As you can see, this intervention benefits our patients, our health system, and our payers. We're very excited to continue this work that we began, and our goals moving forward are to improve the lives of patients at Penn Medicine by making this standard of care. That would mean deploying the service to 850 cirrhosis patients annually and 150 post-liver transplant patients annually. That would reduce readmissions in cirrhosis from 29 to 16%, and in transplant from 32 to 18%. In a year, we would prevent 168 readmissions and no doubt save some lives. We would also love to share our knowledge with others, first by deploying our methodology to other chronic disease states, such as heart failure and renal failure, in our hospital, and then through other health systems. And we hope to make Penn Medicine a thought leader in this space by disseminating our knowledge. Enroll other centers in a multi-center trial in order to better understand the problem nationwide, and be the first group to publish telehealth data in the cirrhosis space, and the first to do it on a large scale in the post-transplant space. Finally, we wish to reduce readmissions at a time when they are becoming increasingly important. We look forward to our continued success with your support. I would like to thank the entire LiveBetter team for each of their individual areas of expertise, without which we would not have succeeded. We would also like to thank the Center for Healthcare Innovation for this amazing and transformative opportunity to further a cause we're passionate about.